Dr. Lancet, welcome to the HemOnc Pulse. It's our new podcast here, sponsored by Blood Cancers Today and Soho. So tell us a little bit about what you are expecting to see at the American Society of Hematology meeting that we're both in right now in the world of acute myeloid leukemia.
Sure. So yeah, that's my focus, AML, and there's really some very interesting new data this year that reflects upon some of the previous discoveries from prior years and the incorporation of novel therapies into the treatment armamentarium of AML. I think we're looking at some very exciting new targeted therapies. I think the ones that have caught my attention include some updates on the menin inhibitor trials. These are very active agents in patients that have MLL rearranged or NPM1 mutated AML, where we are observing fairly high response rates in that subgroup of patients, many of which are durable and lead to MRD negative remissions. So that's very encouraging for sure, looking at that type of outcome in patients receiving monotherapy with these agents. There's other, I think, best-in-class agents coming up in the future with menin inhibitors, looking at covalent bonding agents that have irreversible activity in menin inhibition. I think those are also going to be very promising for the future. So keep an eye on the menin inhibitors. Certainly we're looking at other targeted agents such as antibody-drug conjugates, so the immunogen 632 compound, when combined with HMA venetoclax, has shown very intriguing response rates in heavily pretreated patients with relapsed and refractory AML, and that certainly is another avenue that I think has a lot of potential for those refractory groups of patients, especially those with adverse karyotypes or even p53 mutations.
One of the things that we've always struggled with in the world of AML is elderly AML, regardless of the genomic aberrations that we deal with. Over the past 10 years, how would you summarize the changes in how we treat elderly AML, and how are we defining elderly AML?
Well, I think we have seen general advances in the AML therapeutic outcomes, but that subset of older patients still is representative of a great unmet need where we haven't really moved the needle so much yet. I think that these newer agents that are being explored certainly have utility in older patients, and obviously HMA venetoclax was a major breakthrough in leading to higher response rates and better survival. But clearly, we have a long way to go to improve the outcomes of those patients. I'm encouraged by, again, a lot of the new targeted therapeutic data. I'm encouraged by the utility of allogeneic transplant as an option more and more frequently now for older patients that have good performance statuses, whereas opposed to 10 or 15 years ago, we were more or less frowning on transplanting those patients. And the ability to do that safely now, I think, will improve the outcomes of older patients. I think the key in the older patient population is going to be able to really inhibit the most common adverse targets in those patients, the p53 mutant patients, the ASXL1 MDS-related AML patients that have adverse molecular features. This is the group, I think, that needs the most attention, and these molecular abnormalities, these adverse molecular abnormalities are certainly overrepresented in the older group, and that's where we need to focus our attention.
Well, Dr. Lancet, thank you so much for stopping by, supporting the HemOnc Pulse, and enjoy your meeting.
Great, thank you so much.